All right. So yeah, hi everyone. Nice to meet everyone here. As mentioned, I'm one of the neuromuscular neurologists at CHEO. Better. And I'm going to be going over treatment options, what we have really available now and what's available in the future. There is quite a lot to cover. And so I do invite you guys all to attend tomorrow's presentation as well, where I believe some of the pharma companies are going to discuss things as well. Just some disclosures. I've done some consulting and advisory boards for Novartis and Biogen. All right, so as mentioned, I'm going to go through currently approved as well as treatment that's not approved yet. We know for children who have Duchenne muscular dystrophy, it's not a straightforward mechanism of muscle breakdown. There's a lot of different areas that we can see where the muscle can be damaged. And so while this makes treatment more complicated, it also gives us lots of different areas that we can target to really try and have some improvement for these children. So when we look at treatment, although really today I'm going to be focusing on the neurological treatment, as you guys have heard today, we really need to take a multidisciplinary approach to our treatment for these boys. And so as you guys heard, we really rely heavily on a lot of our colleagues within orthopedic medicine, endocrinology, rehab. There's many others as well as all our allied health. So I'm not going to be focusing on everything they've done, but I know there's already been talks on some of those today. All right, so when we're looking at muscle, you can see here on the left, we've got normal muscle in a person. And then you can see that the muscle starts to break down. So you can see we have kind of early muscle loss, and then you get this later really fibrotic and fatty replacement. So this is what we're really trying to prevent, because unfortunately, once it occurs, it's irreversible. So for what we have approved right now in Health Canada, it's really only 2 corticosteroids. There's prednisone and deflazacort. We've been using these for decades, probably over 50 years, that they've been around, and we've shown that they really work well for Duchenne muscular dystrophy. In terms of why they work, there's a couple probably different reasons, but the main reason is really reducing inflammation and helping to stabilize that muscle membrane. In terms of the differences between prednisone and deflazacort, there's slightly different molecular differences. And so this sometimes can change the side effect profile, really is what we see. In terms of efficacy, we think they both work really well. The main difference being that deflazacort is thought to have probably less weight-associated side effects, although this is really different for every patient, and it's not a hard and fast rule. I know earlier this morning, Dr. Ward kind of briefly discussed about regimens, and we think dosing regimens are all probably relatively equally effective, although we don't know that completely at this point. And so what you'll see probably most common here in Canada is daily dosing. That's what we really find is the most effective. But in other parts of the world, or depending on children's age, they might have 10-day on, 10-day off dosing or weekend dosing as well. All right, so now talking about therapies that are really coming, we talk about those that are really specific to a set DMD mutation, so may only be available to some patients depending on where their mutation is, versus others that are not specific. So in theory, any patient with Duchenne would be able to take it. You need to be closer. Is that better? Yeah? Okay. All right. So we're going to be going through these medications. So the first group is really looking at medications that really decrease inflammation and fibrosis. And so this was already brought up, I know, earlier this morning, vamorolone being the medication. This is not Health Canada approved, but was recently approved in the US by the FDA. So the only way to access it right now through Canada would be through clinical trials. What we've found so far, so vamorolone is a type of synthetic steroid, but is missing a part of the molecule, so it's thought to have less side effects than our regular prednisone and deflazacort steroids. We know efficacy overall is relatively similar. So if you look at these graphs here, the orange group is our kind of standard of care group. So this would be patients who are on our standard of care steroids. And then the blue group are those patients who are on vamorolone. So we know their functional testing is overall relatively stable for the data we have. However, what we know is different is this height percentile, which I know is talked about a lot by Dr. Ward and her colleagues. So this is thought to be the main benefit of vamorolone. And more study has come out that's really showing the higher dose, that 6 milligram per kilogram is probably the most effective dosing. Going on now into treatments that really work to increase the muscle mass. So again, this is a non-specific treatment. HDAC inhibitors, or givinostat is the other name. This was also recently FDA approved, but it's not Health Canada approved. There's lots of different conditions that this has been looked at in, but for Duchenne specifically, we know that there's a problem with regeneration within the muscle, which is caused by, a long pathway of muscle degradation. And one of that is thought to there would be this loss of nitric oxide, which causes oxidative stress, and then hyperactivity of this histone deacetylase. And so by inhibiting these HDAC, the thought is that we can really help the muscle regenerate, essentially. And so what we've seen so far in this is that patients are showing slower decline on their functional assessments than those who wouldn't be on it. And so right now in Canada, there's trials that are ongoing with this. Anti-myostatin kind of medications is the other big group. So this is a super interesting way they found this. First they looked at some animals, these racing dogs who were quite muscular. And then they found these patients. This was actually a child you can see in the image who was, the mom was a former athlete. And once the baby was born, they noticed that the baby had really remarkable muscles. They were quite hypertrophied and large. And what they found was that this patient had a mutation that essentially prevented myostatin from being produced. And so because of this, people started looking into how this could be used in treatment. And so there's lots of clinical trials ongoing for many different disorders, but there are some treatments ongoing right now in Becker muscular dystrophy, which is exciting. It's one of the only treatments we have for Becker. Okay, now going into medication that really works to replace dystrophin. So Atalurin is one of the most well-known medications. Atalurin's not approved in Canada or the US, but I believe it is still approved in the European Union. And so Atalurin works for patients who have a nonsense mutation. So we know this is probably about 10% of patients with Duchenne. And what it does is it forces read-through, kind of trying to induce that reading frame so it's able to be read through and produce some functional dystrophin. What they found was that there was improvement in the 6-meter walk time for a subset of patients in the data that's been out. But more recently, they wanted to actually compare this to real-world data. So there's something called the STRIDE registry, which has been looking at patients who are on Atalurin in countries where it's been clinically approved. So this is real-world data. It's looking at patients who have been on medication for at least 5 years, and it's comparing it again to this natural control population who would be on just steroid regimen. And what they found is that there was a difference in loss of ambulation. So you can see it's about a difference between 17 years and 13 years, so quite significant. And then we also found that there is a difference in age when your FVC starts to decline. Okay, now going in a little bit to gene therapies. So there's two kind of areas that we approach this. One is a gene modifying therapy. So these would be your exon skipping medications. And then the other is gene replacement with either mini or microdystrophin. So when we're looking at how these medications work, it depends on what area of the cells it affects. So when we're looking at the DNA, this is kind of your master copy. This is your single one copy that's very important. And this is what gene therapy works to replace. RNA is kind of like your blueprint copies. So these are all your copies that you would send out for construction sites to work on. And this is where your exon skipping therapy would work. And then the final step is your proteins, and this is what it's hoping to change. These are like your construction workers. So when we're looking at the dystrophin gene, I think everyone's aware it's quite large, and there can be different mutations affecting different exons. So if we look here, exon 50 has been removed, it's deleted, and this disrupts the reading frame. So you could see that the ends won't go together. The end of exon 49 will not match up with exon 51. Therefore, it can't be read through, and you're not making any dystrophin. When we look at exon skipping treatment for Duchenne, as I mentioned, normally the ribosome is able to read through that mRNA, and it can make normally functioning dystrophin. However, when you're missing some of these exons, so here you're missing 53 to 55, the ribosome isn't able to read it all the way through. So you get this partially functional or not unstable dystrophin. So what exon skipping therapy works to do, if you look at these exons here, we know 52 and 56 don't go together. But if we somehow skip over exon 52, then we're able to still read through. You've got two flat ends that are coming up to each other. And then therefore we can produce some functional DNA. So this is the whole point of the therapy. And so you can see it's very specific to an individual's mutation. So right now there's no exon skipping therapy that's approved in Canada. There are 4 that are approved in the US, and there's many that are still in trials as well. The 4 that are approved in the US are the most common areas that we see mutations. So it covers about 30% of patients. But you can see if there were enough that were manufactured for all the amenable deletions, then it would cover almost 80% of patients with Duchenne. So there's quite a lot of promise here. In addition, there's new next generation kind of these exon skipping. So exon skipping therapy right now uses something called antisense oligonucleotide. And these next generation exon skippings really, there's an additional piece that really tries to buff it up and cause increased tissue penetrance. So the point of these next generation ASOs is that it really helps penetrate the tissue, meaning we'll get more dystrophin produced, and it also really helps to get into the cardiac tissue, which is not something we've been seeing with the currently FDA-approved exon skipping. So really exciting there. It also is working to reduce the frequency. So exon skipping that's approved in the US is weekly dosing, and some of these newer ones are every 4 to 8 weeks. So a lot more reasonable for people's lifestyle as well. The last group of medication is going to be these gene therapy medications. So gene therapy medications have been around for quite a while, although we've been learning about them, and for Duchenne, these have really just been more recent over the last kind of decade. So the first AAV gene therapy, which is when it's delivered to the body through a adeno-associated viral vector, was actually in the late 90s. And then the first approved medication was for something called Leber's congenital amaurosis. You can see it's quite expensive, which is something that we're dealing with all gene therapies. And probably the most common gene therapy you guys may have heard of that us in the neuromuscular world use all the time is the omniscient apoparvovec, which is for spinal muscular atrophy. For what is approved, again, unfortunately, there's nothing approved in Canada just yet, but the FDA has approved, and I apologize, I'm not going to say these names very well, the delanteristin gene moxaparvovec, which is approved in the US for patients who are 4 years of age and older. And then there's lots of medications, again, that are still in trial as well. The problem, which what makes gene therapy really difficult for Duchenne, as I mentioned, is because of how big that dystrophin gene is, and the viral vectors that we need to use to get these into the body cannot hold the whole dystrophin gene. So again, the way these medications were actually found is quite interesting. They found there were 2 patients who were doing wonderfully, who are still walking, I apologize, into their 60s, who they found to actually have a dystrophinopathy who were missing almost 50% of the dystrophin. So after looking at these patients, they realized maybe not all exons are created equally, and there are some that are more important than others. So through this, they were able to create these mini or micro dystrophin. So it's a smaller form of dystrophin that does fit into the viral vector and can be put into the body. So far, there's been some good studies that have looked into this. So in this study, they looked at muscle biopsies, which were the primary outcome. So if you can see in these images here, the image in B on the far left, top left corner, shows you what control muscle looks like. So the red is your dystrophin. At baseline, you can see these patients had really no red lighting up. There was no dystrophin that came. And as they were treated, you can see it's not normal, but there's quite a significant amount of dystrophin that's coming up there. So based on this improvement in dystrophin, this is why it reached accelerated approval in the FDA. They also looked at scores on the NSAA, which is a functional testing score. The higher the score you have, the better, the more independent you are. And they found that there were differences in patients who were treated with this gene therapy versus those who weren't. In prior studies, it was a little bit, the results are a little bit confusing. Originally, their NSAA only showed really improvement in the younger patients, but not the older patients. And even a study prior really showed only changes in their functional improvement. So on the time to rise from the floor, the 10-meter walk time. But as I mentioned on that Endeavor trial, the NSAA was positive. The only other one I'm going to mention here is a medication done by Pfizer. So this was a phase 3 placebo-controlled trial in ambulatory patients aged 4 to 7. And unfortunately, this did not meet the primary endpoint or any of the secondary endpoints. So we're still learning exactly what that means for our patients who are part of this clinical trial. All right, and I will end there. As you guys can see, there's quite a lot of different medication that's really targeting certain gene specific or parts of the pathophysiology. There's also many treatments that I did not bring up today that are still much earlier in the treatment trial, but I think in the next kind of 5 to 10 years, we're really going to be having different conversations. So I think there's lots of hope here. Thank you. Yeah, of course.
Hello? Yeah. Sorry, that was really loud. Last year, when we got in a discussion group, we discussed that the studies that took place in the States would never be approved here in Canada. They'd have to start over. They didn't use enough boys, or the statistics weren't significant enough. Or can you tell me more about how that happens, that would they have to start over in some of the studies in Canada?
Yeah, it's a good question. So I think when Health Canada looks at getting a drug approved, they use quite rigorous data, and oftentimes you don't need to necessarily repeat a lot of the studies that have been done. They can use them in addition to creating new studies. So I don't think studies that have been done in different parts of the world are necessarily negligible, but sometimes Health Canada needs to have a little bit more evidence of good efficacy. And so they do need to sometimes do additional trials. Not necessarily, no. Yeah, but I think that's why we see sometimes the delay. Health Canada is quite rigorous. And I think part of that is because we have a publicly funded healthcare system. Yeah.
Yeah, we're just getting questions about the approval and why they're not approved in Canada, but I know you can't answer that fully. So unfortunately, we can't really answer this.
Yeah, I am hopeful that we are going to have some medications that are approved coming up. But as I said, I think it's just the Health Canada process is a little bit more rigorous. They need a little bit more evidence prior to it being approved. And I think overall that's really meant for patient safety. So of course it's very frustrating that things aren't approved here, but I'm hopeful they will be soon. Yeah.
I won't say too much, but I'll talk a little bit more about this when I give my talk about selecting the right clinical trial and the approval process. But one of the other big differences with the FDA is they also have an expedited review process. So it's possible to use surrogate markers for improvements with disease. So just as example, if the CK comes down, that would be seen as a surrogate marker that could be predictive of a clinical improvement with DMD that would allow for a preliminary approval to take place. So because of that expedited approval, when there's a clinical need, it allows for things to move faster in the US as a consequence of that. But Europe doesn't have that. The EMA, Health Canada does not have that. They really do rely on there being demonstrable clinical benefits in order for them to accept there being, I guess in their opinion, more of a meaningful change. So it does lead to an additional layer of delays, which is incredibly frustrating for all of us, particularly people that are waiting for those treatments.
right, thank you.